Welcome back to video 2 of 2 of Orientation for Internal Medicine's Quality and Safety Program. We're going to pick up right where we left off, discussing cohort-based longitudinal projects. A lot of these projects have resulted in some pretty interesting outcomes. Some of them have resulted in measurable improvements. One of the best examples is in one of the first years we did this, one of our cohorts used the VA's medication ARCA, or to look at all of the ordering errors for antibiotics that were being reported through the incident reporting system at the VA, and they took that information and were able to use it to create a creatinine clearance pop-up that resulted in a 75% reduction in renal dosing errors for antibiotics. And when you work at the VA, you're going to see this pop up, and it's tremendously helpful. It feeds you directly into an ordering menu that matches the creatinine clearance for that patient, which can be just very helpful in not only ordering antibiotics, but also in making sure that it matches the patient's creatinine. Other projects have resulted in significant reductions in other issues like PICC line placement in inappropriate patients or for inappropriate reasons, and they structurally recreated how you order PICC lines at the VA through one of the cohort projects a couple of years ago. And you'll see this menu when you work at the VA as well, and it forces you into ordering PICC lines on patients for whom it is appropriate and does not allow you to order PICC lines on patients who have a higher degree of risk associated with that procedure. Some of our projects have resulted in sustained institutional process changes. You will see at the VA, maybe after our COVID issues have settled down, one of the workflows that was recreated at the VA was the implementation of physician-nurse telemetry rounds. And this came from over a nursing concern that they'd been deemed by the Joint Commission that there was overutilization of telemetry, and largely that they were using it on expired orders. And so this was a nurse-resident collaboration that recreated the workflow of how tele was assessed and built this nurse-physician dialogue into the daily practice of the teams. The way we order C. diff testing at the VA has completely changed based on the efforts of one of our cohorts a few years ago. These pictures were taken from a project last year where one of our cohorts really looked at the way we were teaching our incoming trainees about patient safety and hazard awareness. They did a staged educational program where they created what you could call room of horrors, or just hazard-fraught rooms, and brought learners into simulation environments where they were asked in the first simulation to identify errors and hazards in the room, and then were fed directly into incident reporting boot camp where they inserted those hazards that they'd seen into the reporting system for the institution, and then came back 6 months later and rounded in teams on a series of rooms and were asked to assess the severity of the hazards present in each room. The outcomes on that project are still being analyzed and are a good example of what I've bulleted at the bottom here, that a lot of these projects have resulted in presentations and publications both locally, regionally, and nationally, and have offered a lot of scholarly activity for the residents that have been involved. Additionally, quality and safety in this program are identified as an ongoing strength of residents when they are asked in their ACGME survey about strengths of the program. When we reflect on what makes this model of quality and safety education so strong, I think, again, it goes back to that theme of making it real. We take these concepts of quality, but we really apply them and teach them in a real environment where we're making real changes. I think it helps that we use a longitudinal approach, that we stretch these projects out over the course of an academic year. It's important to remember that not all projects are suited to a longitudinal approach, and we'll cover that in just a second. I like it that our projects are really owned by the residents involved in undertaking them. I think it gives you guys a stake in the clinical environment in which you work, which is critical to not only your future investment with your employers, but also just to the satisfaction of knowing that you're doing something to better your clinical environment. We engage local institutions. They have a better recognition of who our residents are. They involve them in other things. And I think our educational projects have something to do with that. And learners continue to appreciate the training. Lessons learned. Some of the lessons we've learned throughout the years is that data acquisition and management is challenging. And so before you start a project, it's always important to ask yourself, how am I going to get this data? How hard is it going to be to collect? I've always found that projects are most successful when we are creating and managing our own data sets without having to ask for help. But sometimes you can find really great projects that have ready streams of information and data that you can just take advantage of as long as you've established that before moving forward. Best project selection means really thinking about a project that is perfect for the fact that you're asking 20 of your colleagues to invest in it over the course of a year. Some projects in some institutions are really more tailored to rapid cycles of improvement where they want results on a monthly basis, and that's not really the right project for your group. You also want to look at projects where, for lack of a better term, there aren't too many cooks in the kitchen, that the institution cares enough about it that they appreciate that you're taking it on, but not so much about it that there's multiple other groups working on the same thing, because then you might find that your results are more muddied. We've had a lot of success with projects that have engaged other professions, pharmacy, nursing, and others, because then stakeholders are involved, and I think it just improves a lot of communication interdepartmentally as well. I think other things that we've found is that the integration of your quality and safety education across your training is useful, and so remembering some of the other tools that you picked up in other places can be helpful in undertaking a project with your team. Other expectations of this year: attendance is expected. You have protected time for these activities, and so you could otherwise have been assigned to a clinic, but the residency program has seen this as valuable, and the ACGME actually requires you invest in this specific education content, and so attendance in these sessions is required. We really appreciate it when you guys participate, because we feel like in participation you get the most out of it. Additionally, at the end of every year, your cohort will be asked to give an end-of-year presentation to the entire residency, usually within the context of a noon conference. We also strongly encourage that you guys work together to promote some sort of other scholarly activity. And this may be as simple as presenting at the local ACGME meeting at the end of the year, or as complex as going to a national meeting. It's important to just take a moment and pause on the fact that we are converting content to virtual, at least for the first part of this year. So all of your meetings, systems of care didactics and wellness didactics, and your quality cohort groups will meet in either Microsoft Teams or Zoom, depending on the comfort of probably your faculty leadership and the comfort of the presenters for these meetings for systems of care and wellness didactics. PGY level task groups have been the way I've always assigned the intervening work between sessions, but it might be worthwhile to consider in your cohort whether mixed level groups, a mixture of PG3s, 2s, and 1s working in the intervening time together might be good in terms of mentorship and coaching related to these projects. I welcome any ideas you guys have on how we can make this more meaningful for you, and I look forward to working with a lot of you throughout this year. This ends orientation for internal medicine quality and safety, and you can debrief this content when you guys get together in your first cohort meeting in your ambulatory week. Have a great day.